So let me kick off with some of the questions that we've had coming in. There must be loads of Lyme infections that aren't recognised. We've been asked, what happens to those patients? Not all get diagnosed at a later stage either. Does the infection sometimes clear itself? Who would like to kick off?
Yeah, well, I can actually address that. I mean, let's use syphilis as an example. Syphilis, you get an ulcer when you're 18 and it disappears even without treatment. And then in a setting of immunocompromise, you become 60 like me, and you become immunosuppressed from your immune senescence, or you go on steroid therapy, or you develop HIV. Syphilis reactivates, so it never goes away, or you become pregnant and it reactivates. So the issue is that people speculate that the Borrelia just spontaneously disappears, but it's the same type of organism as syphilis. The issue is nobody studied it. People have studied syphilis, so I think it's up for speculation. But there are cases of in research studies been able to isolate Borrelia years and years and years down the way. So I don't think it disappears. I used the example of the GP from Liverpool who had the lesion reappear 2 years later, biopsy proven Borrelia 2 years later, despite 2 weeks of doxycycline. So I think it persists, and it's a low-grade pathogen, so it doesn't kill you quickly. I just think there's a whole process of immune cascade, and I think people are diagnosed with arthritic conditions, or they're diagnosed with neurological conditions or pain conditions, and it's due to this low-grade pathogen in the tissues and the immune system activating it. But it's all speculation because no research has been done. More research has been done, I think, with long COVID in the last year than has been done in Borrelia since 1975, because it's a hugely debatable field. And patients are so often kind of characterized after nobody can figure things out as malingering or making up their symptoms or having psychiatric symptoms. So we do need better science. But I think the bacteria persists for years and years if it's not treated.
Thank you for that, Dr. Lambert. And here's a question that I'm going to direct to Dr. Hussain first, but I suspect Dr. Lambert will want to come in on the back of this one. Do the organ symptoms present clinically if the person's diagnosed in the early disseminated stage, or can they be silent till later in life? And there's a follow-on from that, which is, do they need a blood test after treatment to check for organ damage or to see if the infection's cleared? So Zara, if we can come to you first and then to Dr. Lambert.
So it depends on the organ. So like I kind of covered in the talk, they might be presenting, for example, with a facial palsy or pericarditis or joint swelling. And that's the organ involvement revealing itself to you. The trouble is sometimes when people present with those things, it isn't always immediately obvious that Lyme disease is the underlying cause. And indeed, those things do have multiple different causes. So it's Responsibility of whoever's treating the person to look holistically at what else might be driving this. So do the organ symptoms present clinically if the person's diagnosed in the early disseminated? So yeah, so if they're presenting that way, they've revealed themselves to you. And like Dr. Lambert discussed earlier, and you can have late disseminated disease where it can present, some years down the line. But I'll let Dr. Lambert cover the question from here.
Well, we don't understand, why some people get Lyme and have really minimal symptoms, and some people get Lyme and get disseminated disease, just like with COVID, the same kind of thing. So there must be some immunological factors involved as well. So it has protein manifestations. Many different organ systems are involved. Some people get sick within a few days of getting a tick bite. Some people don't develop symptoms for months and months later. And we don't know if that's related to the bacteria that's been inoculated or the host. So there's lots of different factors involved. And I've seen people, for example, not develop, arthritis type symptoms for 3 to 6 months after developing the tick bite, and I've seen people unwell within a couple of days. So I think there's a variety of host immunological and pathogen factors, that are involved in this. So, but we don't understand.
Thank you for that. Thank you for that. And here's another one, again for you, Zara. How can we be sure that it's an EM rash and no other cause for the targetoid rash? What would you say to that?
I mean, the first thing is, what else can cause a targetoid rash? There aren't many others. Like, the EM rash is pathognomonic. There isn't anything else that can be causing it. I mean, yes, we can have ringworm, but generally there are other symptoms associated with that, but it looks quite different. And like I said, that usually the EM rash is 5 centimeters in size or more, but it can be less than that. If somebody's got systemic symptoms like flu-like symptoms, then that's not going to be ringworm. If they've had exposure to the outdoors, it's looking holistically at the whole clinical picture and forming suspicion. But the targetoid rash, there isn't really anything else. EM rash, the only thing I can advise you to do is look at lots and lots and lots of images of the different types of EM rash. You need to form a database in your mind so that when you see it in real life with the patient in front of you, you're then able to recognize it for what it is. And I'll hand over to Dr. Lambert, Professor Lambert.
Well, the thing is that we always talk about the classic rash, it's a painless rash. It's not itchy, but the reality is that there's a wide variety of, kind of clinical manifestations when people get a tick bite. So it can be itchy. It can be the classic rash. It can be, it can be crusted. It doesn't have to be, erythematous. So there's a wide variety of situations. I guess I would say, if I'm out in the country and I come back with and I don't remember a bite, could it have been a spider bite? Could it have been a mosquito bite? Could it have been a tick bite? Could it have been a sandfly bite? It could have been a wasp bite or a sting. It could have been lots of different things. But so it's not just about the rash, it's about your suspicion that it could be Lyme disease. And then if there's a doubt, I think you should also, counsel the patient that if it's classic Lyme disease and you think it's Lyme disease and they pull the tick off it, the bacteria is in the skin, you should go ahead and treat. But if there's a doubt, you should actually counsel the patient that you're not sure. And if they develop systemic symptoms down the way, even months and months later, if they start developing fevers, if they start developing non-specific arthritis, migratory arthritis, then that's the red flag that bite that they had and that funny rash that you weren't sure about, that was Lyme disease. So not people make mistakes all the time. This is the point. There's no classic rash for Lyme disease. There is a classic rash, but most people don't have the classic rash. So I just think you have to have a high degree of suspicion when patients present with symptoms and they have a preceding rash that could have been a bite, that Lyme should be entertained as part of your diagnosis.
Thanks very much for that, Dr. Lambert. And a very quick question, I think, for you to answer is, what supplements do you give along with antibiotics? When you mentioned them, can you expand on that a little?
Right. Well, see, if it's early on, I don't think, then I don't think people need an awful lot of things. But like I said, if it's later on, patients have they have pain that it's not controlled by narcotic pain medicines very often. They have inflammation throughout their body, they have exhaustion. And I've just developed my own protocol and things. There's a product called N-acetylcysteine that's been studied for chronic fatigue syndrome. So there's turmeric with black pepper, which is a natural anti-inflammatory that I find kind of helps people rather than kind of giving them Neurontin or codeine. Low dose naltrexone, we're not going to talk about today. I don't give that to every patient with early Lyme disease, but if they've had Lyme for months and months and years, there's lots of data on using low dose naltrexone as a natural anti-inflammatory and as an immune modulator to repair the immune system. So there is no recipe, but I've been doing the same thing for people with long COVID. People with long COVID now are being studied, but nobody's doing any intervention. I think long COVID is a post-infectious inflammatory autoimmune condition, and you need to do something to help them repair the immune system. They get this repeated inflammatory responses, crashing, exhaustion. So I think there's no proven treatments for long COVID. There's no proven treatments for long Lyme, as we call it. Critically, with long Lyme, there's a bacteria there, so antibiotics are critical, but antibiotics alone don't kind of take care of all the other symptoms. So I have my own kind of protocol that I've just used for patients, including low-dose naltrexone, including natural anti-inflammatories, using probiotics, lots of different therapies, complementary therapies, and top of the antibiotics to repair the immune system and to assist patients, because it sometimes takes months and months to get them to the point where they have resolution of their symptoms.
Thank you for that. I think you're bringing out for us the fact that the longer it goes on before diagnosis and treatment, the more difficult it can be and the more complex, but it's the holistic approach that makes a difference too. So thank you for that. I'm watching the clock, everyone. And we're at 8:15 now, 8:16 to be precise, and we did promise the first section of the Q&A would finish now. So for those of you who cannot stay with us, then we just want to say thank you for joining us tonight. We will carry on. We've still got some more questions that we haven't yet answered. I hope many of you will stay, but can I ask you before you leave to please do the evaluation in the chat box. It's electronic, it's a couple of minutes it'll take. We really would value your feedback and any suggestions of topics that we cover from here on. So if you can stay with us, let's carry on with some of the questions. Some are being answered along the way. Here's one which says, in people who are doing outdoor sports, such as marathon runners and fell runners, do they typically return to their previous level of their sport if they get diagnosed in the early disseminated phase? I think that's probably for Dr. Lambert again. Right.
Well, I think there's this condition that if you look at the medical literature, Johns Hopkins have studied this, called PTLDS, post-treatment Lyme disease syndrome. People are still sick with symptoms despite being treated. They can go on for years and years and years, and like I said, it's just like long COVID, certain percentage of people. I've got some nurses who are infected March 2020 and they're still unwell, and we don't understand why. But I think, like I said, I think if you treat people appropriately and you support them, most people recover from the infection. But like I said, it's complex. Nobody's done much research into long Lyme, persistent Lyme. Nobody understands what's going on in the system. But I would say that it's hard for patients to be previously, marathon runners, and then a year later, being treated for Lyme, still unwell, never getting over COVID, and basically crashing after running 2 kilometers when they could run 30 miles a day, So it's really hard. But my observation of managing these people is if there is an active infection there, they do respond to the antibiotics. If you do repair the immune system, they do recover and they do get back to normal. Not everyone does, but I think that's the goal we should be shooting for. And I think most patients do get better with appropriate treatment and support.
That's encouraging. That's helpful. I have one here which I'll head to Sarah for. First of all, this practitioner is asking, I have a 32-year-old woman who's myriads of symptoms for years, but who improved on doxycycline for something else. So ID and CFS services did not help her. She's not depressed. Should I be testing for Lyme? I've given her doxycycline for rosacea and she feels better already. Sarah, would you like to comment, and then we'll pass to Jack Lambert?
quite a tricky one, isn't it? Because so she's had symptoms for a long time, but you haven't given us any history of, did she have outdoor exposure? Was there any history of tick bites or being in situations where she might have been bitten by ticks? What her other symptoms might be? Yeah, this is one where I would be discussing with other colleagues. So I'll hand this over to Professor Lambert.
What's the question is, should you treat for a longer period of time, or, you know, is it appropriate to treat with doxycycline? You know, I guess I see patients all the time in infectious diseases, and I get referred patients from hematology of, you know, patients with thrombocytopenia, patients with unexplained neutropenia, patients with ongoing sweats, and you know, I see patients who are returning travelers, you know, and you rule out malaria, you rule out other infections, and very often, if it's not resolving, I put patients on a course of doxycycline. And I would say that many of those you could investigate them for years and years and not figure out what's going on, but very often it's a doxycycline responsive infection. Now, is it Q fever? Is it a rickettsial infection? Is it Lyme disease? Is it something else? We don't have good diagnostics. We don't have PCR tests, and sometimes the antibody tests are negative. So I'm not saying everybody should do this, but I'm saying we put people on doxycycline for skin infections for years and years, and then we say, oh, antimicrobial stewardship, we should be treating people unless we know what's going on. But I do think that one of the questions I always ask my patients is that, did you receive a course of doxycycline, and did you receive antibiotics for another reason, and did your Lyme symptoms improve, or you know, and they often say, yeah, I got better, then I get worse again. So I actually have a low threshold for treating people and treating people for longer. If I think I'm very suspicious there's an underlying infection, and doxycycline covers not just Lyme disease, but it covers many other pathogens I've just mentioned. Q fever, for example, I had a farmer who came, and leptospirosis. I have farmers who come to me and say, I think I've got Q fever. You know, they test themselves, or they think I've got leptospirosis. They come in with a diagnosis, and sometimes I do the testing, and they've been sick for 6 months, and I put them on a course of doxycycline, and they get better. So I'm not saying we should be throwing antibiotics at everybody for every infection known to mankind, but I think it's sometimes kinder where there's a clinical suspicion that they've responded to antibiotics and they got worse again when you stop the antibiotics. It just says to me that maybe they need a longer course of those antibiotics.
Thank you, Jack. And can I just bring in Dr. Cruikshank at this point as well?
Yeah, I was just going to say that that the NICE guideline allows you to treat based on clinical suspicion. So you're well within guideline limits to, if you may do a test, if it was positive, then obviously you've got an answer, even if it's negative. If the previous doxy was effective, then treat at the dosage indicated for Lyme disease, plus maybe another antibiotic if you need a full 6 weeks, and see where you are at that point. You cannot be criticised for that if you're within the guideline. Thanks.
That's helpful, Anne. Thank you. Good practical point there. And here, I don't think I can access it here in Edinburgh. Jack, do you want to say a quick word about tests?
Well, I think Lyme is a clinical diagnosis. You don't need a test to diagnose Lyme disease. Patients do foreign tests, and people say those foreign tests are not validated, they're not accurate. Everybody has a positive test, but I see people all the time following a tick bite. They're denied treatment because the Irish Lyme test is negative, and they go to Germany and they come back positive for anaplasma, and they're positive for Lyme disease. And I don't care if it's a German test, I don't care if it's an ELISpot, I don't care what it is, but it's helpful for me. It is helpful for me. So I think you don't need testing to diagnose Lyme disease. There's also a test called the TickPlex Plus, which is actually, people say, oh, we don't recognize that because it's a German test. It's actually a licensed test. TickPlex Plus comes from a company in Finland that was a biotech company that was developed, and it's an antibody test, and it tests for not just Borrelia burgdorferi sensu stricto, it stands for other strains of Borrelia. The most common strains of Borrelia in the European Union are Azafrei guerinii, Borrelia, sensu lato, not sensu stricto, and other co-infections. And not everybody has a positive test, but these tests can be helpful for me. So I don't discount any test that I see, but once again, most importantly, since we don't have PCR tests, there is no PCR test for any of these infections because the number of copies of the bacteria in the system is tiny. Even in acute infection, you're dealing with 10, 20, 100 copies of Borrelia circulating. Hepatitis B, you're dealing with 100 million copies of hepatitis B. So you've got a PCR for that test, but not for Lyme. When I see patients and I think they have an infection, I tell them, I think there's an infection there. But if they don't respond to the antibiotics, I'm the first person to stop it. So I think it's a clinical diagnosis, and whether they respond to the treatment, that's the critical parameter. We accept private tests for other infections, but not for Lyme disease. So I just think we have this huge, reluctance of consultants saying, oh, we don't trust the German tests, we don't accept the German tests. I think every test, whether it comes from IGeneX in America or Armin Labs in Germany, can be helpful, but you don't hang your hat in a test. You don't hang your hat in a test. You hang your hat on a good history, clinical manifestations, and response to therapy.
Thanks for that,
Could-
Dr. Lambert.
Could I interrupt very quickly, Arlene? Just to say, from Zara, the point of Zara and I in general practice, and talking to a lot of the audience who are probably primary care, our job is hopefully to pick it up at that early stage. I think keep remembering that that's one of our aims today, is to help you pick it up at the early stage when early treatment will work. And that hopefully patients won't be getting to these complex levels that Dr. Lambert's having to treat. But feel confident in your early diagnosis, and get in early, I think is the important thing. Thanks.
That's helpful. Thank you, Anne. That's a helpful practical point as well. I think we've got time for maybe just one or two more, although there's a few more. Jack.
Just give me one more, then we have to go.
I know you like a sharp finish. Okay, how about this one then? Does the bacteria turn up in joint fluid, and can you culture it?
Yeah, so in research studies, yes, you can. You can actually, so they've done studies of Lyme arthritis. And, in research studies, you can actually culture Borrelia. Yes, you can culture Borrelia. So it does show up in the joints, and it is present in synovium. So yes, it's not just, and interestingly, 30 years ago, rheumatologists used to treat reactive arthritis. They didn't have any monoclonal antibodies, they didn't have methotrexate. They actually treated patients with reactive arthritis with antibiotics, not biological modifiers. So and 60% of people responded. So there's probably lots of infections out there besides Lyme disease, chlamydia, pneumonia. Patients get chlamydia crotomatis, the sexually transmitted bacteria, causes Reiter syndrome. They get an arthritis, and you can actually culture chlamydia from the joints. So in research studies, you can actually isolate the bacteria, whether it's Lyme disease or chlamydia trachomatis. So this is an infectious arthritis that does respond to antibiotics.
Thank you very much.